at NCL and Camden Training Hub. Just a few nursing CPD updates first. We'll put most of these, if not all of these dates in the chat because there's actually a lot of different dates just to quickly run through. But we've got leg ulcer training at the Roy Shaw Centre. First session's tomorrow, and then there's another one on Wednesday, January 29th. Introduction to Travel Health, which is a 2-day course on the 5th and 6th of Feb. And a travel health update on the 28th of January. Venipuncture and cannulation, 21st of January and 25th of March. That's a Tuesday on both dates. And we've also got the Hartman's Wound Care Education modules. The first one was last Friday, which was actually really good, but there was only about 3 people, I think, that showed it, and I include myself in that. So it was a poor turnout, but I found it very useful. So if you do have the time to make those, they are very useful, and it's almost like a tutorial really around wound care. So there's lots of different dates coming up over the next 6 months for those. There's one a month, and they're on things like wound bed preparation, exudate management, skin tears, burns, lower limb management, and prevention and management of wound infections. So yeah, try and make those if you can. There's also the professional nurse advocate, nurse educator pathway sessions coming up. Now, this is a session designed for GPNs, which basically clarifies the various routes and training options available to become a registered supervisor in primary care, and also just give you the opportunity to discover networks and support your growth in mentoring and supervisor roles. So there's various sessions for these across the boroughs. They're always on a Tuesday, and they run through November and December. And finally, the student nursing associate apprenticeship program is up and running. We're looking for more student nursing associates starting in April 25. It's in collaboration with the Middlesex University, so expressions of interest for that close on the 25th of November. And I think, Barbara, there's not any updates from Chema, is that right? And Amina?
We did have one from
A couple?
Amina.
Okay.
I think she might be on the call right now.
Okay. Amina, are you there?
Yes. Hi, Carl. Yes, I'm here. It's just a very short update, if you don't mind me sharing.
Of course, yeah.
Oh, here it is. I just forgot for a second how to share. Here we go. Okay. Can everybody see that?
Yeah, I can see that.
Okay, so this is it's a reminder because it did go out in the NCL newsletter, and it's regarding the Teach and Treat program. And this is basically a London-wide initiative. It's fully funded, and it's basically in place so that community pharmacists can access the independent prescribing course. And what we're doing at the training hub is facilitating this by obviously doing the expression of interest. And the reason I'm bringing it to this forum is because we're looking for designated prescribing practitioners. So any prescribing nurses within this forum or any prescribing AHPs would be able to apply to be a DPP as part of this program. It would be funded, which means that your host organization, that's the organization that you work for, will get funding to be able to give you the time out to develop the training for the IP, for the independent prescriber. So if you are interested, all you've got to do is complete an EOI form, which you can get through this link. The deadline is the 30th of November, so it's very soon. If you have any questions, I'm more than happy to respond via email. My email address is there. If you are interested in being a DPP and are not yet a DPP, you can actually do some online training. So I put the link there for the DPP training. So you could still do the EOI and then do the DPP training in the meantime, because the actual program will not sort of get started probably until, I reckon, March 2025. So we've got a lot of time there for anyone who's interested in becoming a DPP to do that training. It's online. It only takes a few hours, and it's a very, very high quality piece of training if that's something that you're interested in.
Thanks very much, Amina.
You're welcome. I will stop sharing. There you go.
Okay. All right. So first up today, we've got a general introduction to genomics, and did I hear it's just Dr. Anwar Khan speaking? Is that right?
Yeah, I'll be speaking, but Dom will be there. I have to leave.
Oh, Dom's there as well. Okay.
Yeah. Okay. It's a
Okay.
joint effort. Can I share the slides?
Yeah.
Oops. Where? Looks like I'm challenged. And nope. Don't see how I can see it.
Want me to do it, Anwar?
Would you mind? I think
Yeah.
computers were invented a lot after I joined, so I'm used to papyrus and quills. That's the other reason Dom's here. Okay. Well, thank you very much, everybody. My name's Anwar Khan. I'm a jobbing GP in the East End. I do have an academic role at University of East London, but my main role is as a GP lead for genomics. As I would say to you, the genie's out of the bottle. Genomics is now part of our life. We're getting more and more genetic tests that we will be able to order, and we as practitioners deserve to give the best care to our patients, which means getting used to genomics being part of our armory. Next slide, Don. So basically, I'll just talk about basic genetics, and I apologize for teaching grandma suck eggs, but it's worth that we do just get an idea. I'll talk about the importance of family history and some inheritance patterns to refresh ourselves. We'll talk about rare diseases, inherited cancers, and direct-to-consumer testing. I don't know if anyone's following any podcasts on BBC Sounds. It talks about 23andMe and Ancestry and how it's bringing up issues, but worth thinking about. Next slide, please. So I think there's a number of priorities that for primary care that we need to think about. Firstly is education workforce development, and that's where I'm here today just as a starter, upskilling healthcare professionals. Early identification of genetic risk is really important, and really getting used to taking a family history, that pedigree as we call it, should become routine parts of our consultations to identify patients at risk. And then there are some genomic tools that we can use to identify any risk factors. The third point is really about integrating genomic testing within primary care. We can actually now test for cystic fibrosis. We can actually test for alpha-1 antitrypsin, hemochromatosis, etc. So more and more tests will come in to help us start thinking about their risk. And we are thinking, and again, in subsequent modules, we can talk about use of polygenic risk scores. Number 4, that's the raison d'etre of primary care, prevention and personalized medicine. So we do need to think about using genomic data for personalized prevention strategies, but also pharmacogenomics. We are using more and more pharmacogenomic tools to predict drug responses and reduce our adverse side effects. Now, there are things about data management and ethical considerations, and again, that's a whole lecture in itself. But I think for me, the biggest driving force is about equity and access, reducing disparities in access to genomic service across different populations, and developing resources that are tailored to meet the diverse needs of our patients from varying cultural and socioeconomic backgrounds. Integrating genomics into multidisciplinary teams is a very good way of doing that, and we need to think about how we make that easier. So we've developed new referral forms um, for referring into genomics, and that they're integrated within System 1 and EMIS, which allows you to be able to do referrals. And I've timed it. It takes about 5 minutes max. I think the bigger, widest bit is about public awareness and patient engagement. And therefore, we do need to think about how we educate our patients. And hence, it's important to educate our healthcare staff first in order to do that. And then there are issues about research. But I do think primary care does play the critical role because 90% of patients actually go to primary care. That's where the heart of the beating NHS is. And we need to be thinking much more about personalized, effective care and thereby reducing variability and improving equity to testing. Ooh, that was a bit of a mouthful. Let's go to the next one. I think what I'm really want you to think about, any red flags, think of genetics. Think genetics every day, every minute of your working thing. We do know that at least 10% or even 15% of patients we see in primary care have a significant genetic element. But the most obvious ones are where there are one or more major malformations, particularly if there's developmental delay or there are dysmorphic features, 3 or more pregnancy losses. We need to be thinking about patients' consanguineous marriages. Not that they're the sole cause of genetic disorders, by the way. We need to make sure that we appreciate the cultural sensitivity around that. But also a disease in the absence of risk factors or after preventative measures. There are certainly ethnic differences in predisposition to certain disorders, and we need to think about that. But more importantly, earlier than average age of onset. So if you see somebody whose father's had bowel cancer in his 30s, early 40s, that should be a red flag. Okay, next slide, please. Dom, I think you have particular expertise in this, and this is where I do feel a bit of a imposter syndrome talking about this. But actually, the reason I would say it is we GPs have a key role in achieving the 25% detection target. It's a monogenic autosomal disorder. There are high blood LDL cholesterol from birth, and the premature coronary atherosclerosis. I helped Steve Humphries do a module on the RCGP toolkit on genomics on FH, and he shocked me to tell me that there were patients as young as 10 with blocked coronary arteries. So really well worth picking up early. And treatment with uh, lipid lowering therapy significantly reduces mortality rates of these patients. Knowing the family mutation is key for cascade testing and also thinking about statin therapy even in childhood. But the long-term plan did say that we need to improve that to at least 25% detection rate. Because at the moment, only about 7% of those with FH have been identified. So we've got a captive audience. So have a think about that. Next slide, please. So as I said before, 90% of FH is undiagnosed. We've only got 1,500 or so currently diagnosed. And Dom, you might want to correct me if I've got any figures wrong there. And there's a potential 30 odd thousand. And an average GP, we're picking about 3 patients or so on my list. There's 37 missing. So let's do some quick searches. It might be a good QI project if anybody's in a training practice for your registrars. Next slide, please. So as I say, it's not just in FH, but in most genetic disorders, primary care's major role is case finding, early diagnosis. In the case of FH, referral to lipid clinic. I mean, identifying patient at the age of 40, that's too late. And the current average age of FH diagnosis is about 47 years. and really being aggressive with treatment with statins, really high dose statins. So therefore you need to titrate treatment, monitor against targets, and correctly code them in the electronic medical record. But I think what is more important is the cascade testing of relatives. I think the future role will be a cholesterol screening of infants, and the picture there is about point of care testing. And there is a project going on about heel prick cholesterol test at 1 year of age at the time of immunization. Okay, and that might be a future for the next thing. So basic genetics. Yeah, that's it. Thank you, Dom. Next slide. Look, I'm not going to spend too long on that. It's just to remind you of our genetic structure. We've got two copies of each, one from each parent. And we often use words allele, and I'm sure you all know it, but it's really a gene variant. Next slide, please. And again, a bit of facts for your trivial pursuits if you want, but we've got 3 billion base pairs um, and about 20,000 genes. And it's only accounts for about 2 to 3% of our genome. Quite a lot of our genome is redundant and quite similar to mice genome, if you're interested. We call coding DNA the one that makes proteins. They're in exons. Non-coding DNA don't make any proteins, and they're in introns, but they may have regulatory roles, etc. Repeat sequences, particularly, I remember from my days in genetics 30 odd years ago with Huntington's, actually, there's multiple repeats that causes that early onset of dementia and etc. Next slide, please. Now, we use genetics and genomics interchangeably, but we are moving much towards the use of genomics now rather than genetics, because genetics is really hereditary. It's much more at a gene level, whereas really what we want to think of genomics is the complete set of genetic organisms, both the coding and non-coding, but actually how it all works in a functional way. So we are moving much more to genomics. Next, please, Steve. Now, the last decade has been absolutely phenomenal changes. We're now able to test adults, children, even pregnancies, and technology is improving. And with improved testing comes the need for advanced interpretation. So, you know, we've got on the NHS things like single gene testing, small panel testing, which is 5 to 10 mutations. There's larger panels, clinical exome, whole exome, and whole genome. Previously, whole genome and whole exome were in research, but now it's actually part of our genomics medicine service. And we are able to actually analyze a lot more data. And I think this is where the future of AI is going to come in as well. Don't know if you agree with me, Dom, but I think AI is going to be helping us with this tsunami of information that we're going to be getting. Next slide, please. Now, I've talked about all those things like genome and exome, etc. Really, what I'm trying to show in this slide, using the principles from the previous slide, is that if we are actually looking at the genome, we'll see lots of variants, and it will be quite broad testing. As we go further down to narrower testing, we go through exome panel testing and single gene testing, and the choices of tests is guided by one's clinical confidence and information from other investigations, which may point to one specific condition or leave you the broad range of differentials. So the best test is the one that maximizes the chance of diagnosis, but one that minimizes the chance of detecting unrelated mutation. BUS is a common thing, variants of uncertain significance. I suppose in everyday parlance, we call them incidentalomas, don't we? We don't really know what they mean. So it's really important to think about that. Next slide. If there's one thing you remember, is this one. For me, it is critical we all get used to drawing family trees. And in fact, what you'll find, and I found it takes me about 3 minutes to draw a family tree using those symbols. But once you've drawn it, the pattern makes things obvious what the inheritance is. And I suggest you start early and you start using them now. It also helps help inform clinical decision making, but also explaining risks as well. These are some symbols which you can use. And again, if you're interested, very happy to come back to your individual PCNs or smaller groupings and to go through that exercise. Next slide, please. So as you can see, this one's an autosomal dominant, lots of shaded people there because it's a 50% chance of recurrence. So anyone with that variant has that condition. There is something called variable expression. That means not everyone shows it in their phenotype, which is what's shown rather than the genotype. And really unaffected members don't pass the condition on. So Huntington's is the one that I did a lot of I cut my genetics teeth into in the late 80s, but NF1 as well. This is a picture of NF1, by the way. Okay, next slide, please. And as you can see here, there aren't many shady dots, are there? This is a case of cystic fibrosis thing where you've got grandmother and then having a son who then has a daughter who then has a child affected, and this is through carriers. So affected individuals must have inherited two variants, and the heterozygous ones, i.e. those with just one dot, don't express the condition. So there's a 25% risk in subsequent things. And 25% means every time you throw the dice, it goes back to 25% again, not because the risk decreases. Next one, please. So this is yeah, this is a case of Duchenne's, which is X-linked. It's basically it's in mother to son. The famous one is hemophilia, isn't it, from Queen Victoria? Cause of World War One, I think we say. But the carrier mother usually has no symptoms, and carrier mother has a 50% chance of an affected son. Overall, there's 25% chance of an affected child. Affected males have healthy sons, but all their daughters are obligate carriers. Okay, I'm sure you all know this, but it's quite nice to refresh. Next slide, please. This one is achondroplasia. That just means a mutation arises the first time. It's usually dominant, so the affected person will have a 50% chance of passing it on. Next slide, please. We call it rare disease, but they're not that rare. They account for 3.5 million people in the UK, and most of these have a genetic basis for it. But the technical term is rare diseases. Next one, please. We need to be thinking about making that genetic diagnosis early, both from treatment and screening purposes, but also prognosis and recurrence risk. Dom, are you the right person to mention a word about generation study here? Because I think this would fit nicely, wouldn't it?
Yeah, absolutely. So some of you may have heard about the generation study, and you might hear more about it. It was a public launch a few weeks ago. The generation study is a research program off the back of the 100,000 Genome Project, so led by Genomics England. And it is looking to see if we can use whole genome sequencing to screen for rare disease in newborns. And so instead of looking at just the 10 on the blood spot test, it's looking at to see if they can use whole genome sequencing to identify over 200 different rare diseases. And the idea is that we're reducing what used to be quite, they call the diagnostic odyssey. We're identifying rare disease from the get-go, and these are conditions where there are treatments on the NHS as part of standard care that are shown to have a great impact or better impact if they're utilised as soon as possible and have improved outcomes for those children. So that's the generation study in a nutshell.
Thanks, Dom. And again, early treatment will prevent disability, and therefore it will be cost effective very soon after. Okay, next slide, please. So really what we're saying is making a diagnosis early improves the outcome. I won't go too much into the slide. I'll send a copy of these slides uh, um to you all. You can probably read it better than myself, given time and moving on. Next slide, please. Familial cancers. Now, about 5 to 10% of cancers have significant genetic changes in inherited changes to the DNA. Um, Now, it's important to note that just because someone's inherited one of these variants doesn't mean they will develop the cancer. Further changes in the DNA are needed for the disease to develop. In the majority of tumors in inherited cancer disposition syndromes, transformation to cancer requires another mutation, as this risk would show. Next slide, please. I think it probably makes it easier when I talk about a specific example. So, but other than that, in general, if the cancer's earlier than average onset, if there are several members affected, if there are multiple generations on one side of the family, think familial cancer. Okay, and we're giving you a particular pattern of cancers like the BRCA and the Lynch syndrome, and individuals will have more than one primary tumor. Next slide, please. So I mentioned Lynch. I just want to say a couple of words about Lynch. Um, it's hereditary non-polyposis colorectal cancer. I have a specific interest in that. I'm a GP with extended scope in colorectal, by the way. So it accounts for 3 to 5% of all colorectal cancers. They're autosomal dominant. Really important we pick them up. And there's a mismatch in the repair genes. Next slide, please. This is just for you to look at later. Lifetime cancer risks are as put on there. Next slide, please, which is probably easier. Well, the next bit, which probably is actually the management options and things about, as I call it, anticipatory endoscopies quite early in the case of colorectal stuff. The the CAPP2 study showed taking aspirin once a day can significantly reduce the risk of colorectal cancers in Lynch syndrome when taking the usual 75 milligrams. Seems to be the answer of everything aspirin at the moment, isn't it? We're now looking at CAP3. The next study, CAP3, is now investigating the most beneficial dose. Next slide. This has actually become more of an issue now that genomic tests have become cheaper. It's about 150 quid, is it, Dom? I can't remember. It's about that sort of level now, isn't it? People getting to Mother's Day presents and Christmas Day presents, genomic testing. But it does open Pandora's box, even if they were accurate. But there is an issue about accuracy as well. The variations depend on the traits tested, the cost of the test, and I do think a lot of tests are done without actually an understanding of what will happen next. Next slide, please. So we call it SNP analysis, SNP chip analysis. Basically, it's it checks for presence or absence of specific variants throughout the genetic code, and through a particular single nucleotide polymorphism. That's what SNP stands for. All right, single nucleotide polymorphisms, or small insertions or deletions, and they detect the common genetic variants. But when they detect these rare variants, they're often false positives, i.e., they're not really significant that way. So the problem is interpretation of genetic data is complex and context dependent, and identifying variants is not the same as knowing what they mean. So I do think you need to treat them with a sense of caution. And next slide will just show some of the potential limitations, i.e. there's false reassurance, there may be false positives, and predictability is likely to be poor, and children are being tested.
I've got.
And
I haven't looked at. I've got
and
loads of emails.
and
I haven't looked at that.
sorry, someone's joining in. Yeah, and also there are unexpected results like non-paternity. So I I think one of the problems I would suggest to you is that when you're presented like that, you probably want to be saying, go back to the person that did the testing, a bit like neurologists will do the CT scan of the head. All right, don't get into interpreting things that might not be might not be easy to interpret. Next slide, please. So I put GPs, but I mean nurses and any primary healthcare professional. You're likely to first call for advice and follow up on the results. You should not refer them to secondary or tertiary care solely based on these results alone. You should actually offer NHS care, which would otherwise have been offered regardless of this. So therefore, take a family history, do the risk assessment, and do onward referrals as per standard NHS pathways. Okay. I know Angie, one of our geneticists, talks of people being scared about BRCA risks, etc., and they found actually it was totally inaccurate. So in other words, treat them with a big pinch of salt. Next slide, please. There are some educational resources, and Dom, the next slide, you've kindly added on some of the highlights on the next slide. And so can I hand over to people to ask questions, and Dom, you'll join me, yeah? Is there anything you want to add to my very fast run through?
No, that's great. Thank you. Yeah, any questions, everyone? I think just to highlight here, there's a really good series of podcasts, which Anwar and I are also on, aimed at primary care. So if you want to learn a bit more about any of the topics we've gone through today, do have a look at that if you like podcasts. But if there's anything that you really don't understand, some of the genomics education program resources are really good.
Thanks very much, both of you. Does anyone have any questions at the moment? I had a question about like epigenetics and like gene expression. Like not very often, but some patients ask about lifestyle changes and turning genes on and off, that kind of thing. Is there any kind of simple resource that we can use about epigenetics?
Oh,
he's gone. Is he gone?
He's gone. He might have gone. So I mean, epigenetics, I think, is a very complicated thing to explain.
Yeah.
And the actual sort of enactable things that you can do in practice is all sort of in the research realm at the moment. But epigenetics is really sort of external factors influencing gene expression. So a prime example of epigenetics and health is smoking. So if you're smoking all the time, and you're exposed to that does cause changes in your, in the DNA in the lung, which then over time develops into lung cancer. And so there's, it's really, it's kind of marrying up what, the healthy advice that we would give anyway, like, exercising, don't smoke, eat and drink well. That is all, it's all sort of hopefully promoting, no negative epigenetic changes that might then develop into disease. But there's no, I don't think I'm not aware of any sort of specific.
There's no, I think I was just getting no kind of stats or impressive stats from lifestyle changes that could say you've improved your or you've lowered your risk of certain genes being expressed, that kind of thing.
I do remember, I mean, I did the MSc in genomic medicine. I do remember them talking about smoking. And so if you stop smoking by the age of 30 and like properly stop smoking, you can your body will be able to reverse some of that damage, those changes to those epigenetic changes. And so to sort of near normal, if that makes sense. So you'll hopefully reduce your risk that you have if you stop by the age of 30. So I'll talk to my team if there's any sort of fun facts and figures that we can share, but that's the main one that I can think of.
Okay, brilliant. Thanks very much. Catherine's got a question, I think.
suppose I just wanted to really highlight the educational resources that Dom and Anwar have put into the slides here, because some of these are available free through Education for Health, for example, which is great because everybody can access what they need for their level of practice. But I was just wondering, Dom, whether or not there's it likely to be any need for more in-depth knowledge that costs us to train people in which case we might need to factor that into our CPD provision as a training hub.
I think we're very lucky that there is such a wealth of free resources through the genomics education program that there are specific courses that you can go on, but this is a sort of direction of traffic now that genomics, they've got the genomic medicine service since 2018. We've been set up to support the embedment of genomics throughout the NHS. So it's not just clinical genetics now, it's increasingly relevant to every specialty, especially primary care, as Anwar has said, and talking about family history and prevention. And even I think it was last week there's a new MOOC for FH again, to support with the identification and management in primary care. So I think the only thing that that is on the horizon and will might need more investment, or will need more investment, not just in staff but also sort of the resources to support it, is pharmacogenomics. There are going to be more and more pharmacogenomic NICE guidelines that will happen. So that's matching people to the correct dose and treatment according to certain genetic traits. So there aren't genes specifically for one medicine. They have implications for polypharmacy and things like that. So that is something that we really need to be aware of and have that on the horizon. That will quite dramatically change our practice. Not immediately, but it is slowly happening. You've heard about clopidogrel for stroke. That is slowly happening. We're sorting out how the labs will deliver that at the moment, but that will definitely impact our practice.
Thank you.
Does anyone have any further questions? Okay, thanks very much, both. That was amazing. Thanks a lot.
Yeah, do stay in touch, and if there's as Anwar says, if there's anything else that we can deliver in the future, and we've got a newsletter and things like that, so you can sign up to events and things that might be on in the future. But yeah, great to meet you. Thank you so much for inviting us.
Thanks. Okay, so we've got next up is the PC Ambitions Engagement Strategy with Paul Sinden and Catherine Gerrand.
I can't see Paul at the moment. Is he here?
Yeah.
You are here. Good. I just can't see your
in
picture.
the ether. Yeah.
You're in the ether, Paul. Great. For those, I'll leave Paul to introduce himself. For anybody who doesn't know me, I am Catherine Gerrans, Clinical Director, Primary Care Nursing and Allied Health Professions, and I am a practice nurse by background. And Paul and I have come today to talk about a piece of work that the ICB primary care team is doing to understand where we're heading in terms of the development of primary care for the future. And this is your opportunity to help to shape that. This is not us telling you what we've decided. And I really, really want you to take that on board, because this is your opportunity to engage in the conversation and to share your views about what it's really like working on the front line. And does this piece of work resonate with you? Paul, I'll leave you to introduce yourself and to take over from there.
Okay. Thanks, Catherine, and hi, everyone. I'm Paul Sinden. I'm Managing Director of the GP Provider Alliance for North Central London, so working across the 5 boroughs of NCL to provide a provider voice into the work of NCL ICB and the broader integrated care system. So the primary care ambitions have been developed to address, I suppose, a series of challenges that are being faced by general practice. So demand and activity has gone up. So general practice seeing 15% more people than it did before the pandemic. But what we have seen is a reduction in patient satisfaction, particularly around the first point of contact. with practices, less so about the care received once people, in the practice. Practices, and you might have seen this yourselves, working with more and more complex patients, and perhaps you're not always doing it with the right infrastructure in terms of digital support, estates, support from community services is uneven across the 5 boroughs, but also there's more to do around getting the support from specialists in hospitals to support care for people, particularly high risk and people with complex long and multiple long-term conditions. And so whilst general practice is seeing more people, seeing more complex people, what we have seen is that the level of funding that's going into general practice has fallen as a share of the overall funding into the NHS. So it was about 12%, it's down to about 8% nationally. So quite a reduction in terms of the proportion of funding. So we've created the ambitions to begin to think about how do we address those challenges. So how do we kind of work to improve the patient first contact with practices, sort of supported through the primary care access recovery plan? How do we create capacity in general practice to meet demand for same day urgent care, as well as carve out capacity to do more of the preventative and proactive care that sits with general practice as well. So I suppose it's important to say that whilst there've been many challenges that general practice has faced, I think it's important to recognise how general practice has succeeded in meeting many of those challenges. So to name a few things, the new operating model that practices moved to on the outset of the COVID pandemic, and then establishing the vaccination programme alongside community pharmacies, the fact that general practice is seeing 10 to 15% more people than you were before the pandemic. And actually general practice is really fleet of foot. So that wasn't only demonstrated through the response to the pandemic. Recently, general practice has set up a primary care based spirometry service from scratch and done that very effectively, very quickly, to the extent that we're now seeking sort of recurrent funding for it. So I think whilst general practice kind of is fleet of foot, meets many of the challenges that it faces, there's more support that could be provided in terms of overall resource, links to the rest of the system, support for complex patients, from acute services, links into community services, and there's more that we could do alongside resourcing about supporting infrastructure. So does digital funding meet the new way of working in general practice? Estates funding isn't sufficient, doesn't always cover kind of some of the additional roles that we have, as well as the more traditional roles that have sat in general practice. So there's a series of questions about the ambitions, which I'll try to share with you to sort of spend the rest of the time going through. I don't know, can you, no, you've not got them yet, have you? Let me just, sorry, I'll start again. Can you see the presentation on the screen?
Yes.
Brill. Okay,
Yeah.
thank you. So this Catherine sent this out yesterday, just to have a quick look at, not necessarily in detail, but there are a series of questions. Sorry, Sorry, I don't have the thing with the questions in, but if I talk through them, so I suppose thinking to your sort of day-to-day experience, do the ambitions begin to address some of the challenges that you face in your day-to-day work experience? Have we missed anything from the ambitions that you would like to see? And that might link to your current work, or it might be, do you want us to say more about the role of your professions within the ambitions and creating capacity and leadership capacity going forwards? And I suppose, what are the things that you would most like to see change to in general practice to support the work that you take? And sorry, my voice is going a bit as well. So really, are there things that you'd like to reflect back to me about you like to see in a set of ambitions that would support you in your work? And what would you like to see in the ambitions that would raise the profile and potential for your respective professions within primary care? I'm sorry, that was a bit of a download for people as well.
Sorry, it's quite difficult, isn't it, to explain such a document in such a short space of time. I know that we circulated this document yesterday, and the document itself is fairly long and detailed. But even if you haven't had a chance to read it, I think it'd be really good if we could hear from some of you about how you think the challenges that you're seeing can be resolved. So there's thinking about, what are the positive ways in which we could change primary care for the better to meet the needs of our people in our population. I'm not going to call them patients deliberately, because we're talking about proactive and preventative care as well, aren't we, after all? What are the most pressing things that you all envisage? And you're all working in it, you all know what it's like. I just think we really need to hear your voice, and this is your opportunity to feed into this and feel as though you have a voice and can change what is being fed back into the system. So we're really, really keen to hear from you.
Is
So
that
Jada, are you trying to come in?
Sajida?
Yeah.
Oh, Sajida, we're having trouble hearing you. Okay, she's muted.
I can mute. Okay.
So another way to look at it is, are there sort of constraints on kind of your current role, how you work, that if they were lifted would really help you kind of support your practice, kind of get personal development for yourself? So what are the things that would change that would enable you to work to your potential, allow your profession to work to its potential?
Could these be to do with anything? So career pathways and clinical skills?
Yes. So I think as an example, kind of, is nurse prescribing a way for someone to kind of broaden their role, broaden their sort of decision-making capacity within how a practice works, that kind of thing?
Well, for me, I think although it's only one pathway, getting a smoother pathway for somebody that wants to go all the way through the nursing ranks in general practice. So at the moment, if you're a nursing associate in general practice, it's very challenging to top up to become a nurse, and often practices can't do it because there's different sort of obstacles in the funding. And of course, if you stay as a nurse, not everyone wants to become a nurse who's a nursing associate, but if you want to go on to do things like the V300 or the ACP, then you have to become a registered nurse first. So it's quite a barrier for people who are in the practice that can't facilitate that because it's too expensive at the moment. So that's, if there was a way around that and it was smoother, I think that would help retention quite a lot, because I see quite a lot of, I've managed to do it at my practice, but only because of the goodwill of the practice, really. And there's certainly some people that contact me at the moment who can't do it. So that, it's not just the nursing pathway. I know there's always, whenever the government kind of, probably has good intentions for launching different funding opportunities and incentives, there always seems to be sort of nuance and sort of holes here and there that they haven't thought of. But that would be one. Yeah.
Thank you. Yeah, I suppose there might be opportunities through the training hub for kind of at scale offers that might kind of have so many people that could be supported from nurse associate to nursing. There is a workforce plan, I think, that kind of underpins the 10-year NHS plan that's out for consultation at the moment. So there might be things that we could put through that as well to talk about career progression and retention. Thanks, Carl. Saloni?
Thanks, Paul. I think mine's got a lot to do with sort of funding as well, and just thinking about the pre-registration students, and we know how difficult they are to sort of have them in primary care. A lot to do with the support that's available in the practices in terms of sort of time. The funding the practice receives to host pre-reg students it's always sort of been in discussions. So I wonder if there's any thoughts on that. It would help definitely increase the workforce of nursing and exposing nursing students to primary care. So thanks.
Yeah, thank you. That kind of links to what Carl says, doesn't it, about the whole pathway. So from pre-reg to nurse associate to nurse, it seems that we've got various breaks in that pathway that we'd need to kind of get right. Is there anything kind of linked to that, to portfolio roles, perhaps linked to other urgent care services, community services as well, that would support some of that? Catherine?
So I think that's a really interesting question, Paul, because the portfolio roles obviously started off as a GP scheme with the SPIN programme several years ago, and evolved into a national scheme, but was focused purely on new to general practice nurses and GPs. Whereas we have an opportunity now, and I know everybody thinks that fellowships funding has stopped, and that's not entirely accurate. So we need to be thinking creatively about mid-career fellowships. So again, that career pathway piece. How do we get better connections across our different providers? So when we're thinking about general practice, are there any opportunities to share skills with our local diabetes specialists in the local trusts, for example, and maybe having some portfolio opportunities there, and thinking about, is there any way that we can get the system to work to help facilitate that, rather than us struggling to do it all ourselves as general practices or PCNs to do it, or even as a training hub. Sometimes it's quite difficult to leverage those conversations at a strategic level with these big providers. So I think the fellowships portfolio working is an interesting idea. I wonder what the appetite would be for that. It'd be really interesting to hear whether anybody here would actually enjoy doing something a little bit different outside general practice and having an opportunity to shadow somebody else's role for a bit, or switch roles for a bit, or all sorts of ideas spring to mind. But does that interest anybody?
I think that could work quite well with student placement, perhaps. I don't know how it would work, but if the main issue with student placements in GP is that they have to host, they don't get enough money. They get very little money compared to hosting medics. So if the trust could sort of absorb some of the placement cost and maybe have a portfolio placement across primary care with, a bit of district, a bit of palliative, a bit of GP, that might work better for a placement, rather than have, 6 to 8 weeks at a GP practice where they're having to source or, put the nurse up to mentor them, etc.
Thank you. And Nyamka.
Hi, I was just looking at the slides briefly, and I was thinking about your 2D care model. It says proactive care,
Yeah.
and a lot of this stuff is nurses' bread and butter. In all fairness, this is what we do all day, every day. But when I look at these things, I don't know how many nurses get involved in things like Inc. Involved like in terms of the neighborhood teams and looking at things at an MDT level. So I think that when we are thinking of these models and trying to work toward these things, actually to do a lot of the workforce planning beforehand. And when we're implementing stuff, think about our workforce and how we can use them to the top of their level, in all fairness. Because actually, something like an Inc. or old school Inc. sort of meeting, nurses would be paramount in those meetings, but they don't attend because they're doing their normal day-to-day bread and butter. They're in clinics. They can't be taken out of clinics. So it slightly goes back to what Carl is saying as well in terms of the pipeline. But the reason why we have that pipeline and that nurse and associate role is to make sure that the nurses can be in meetings like Inc. and who do MDTs and work with care coordinators and social prescribers. But at the moment, I don't think we're looking at things like that. If we're looking at things at a PCN level or with every staff skill set involved rather than just looking at certain ones that are normally there, but thinking about the nursing team in that as well.
Yeah, thanks, Nyamka. So kind of links to a bit to what Carl and Saloni were saying earlier about that kind of the pipeline, I suppose, feeding capacity, which in turn allows people to work to the sort of top of their role, top of their capacity. So certainly you can see the way forward is that kind of particularly for people with multimorbidity, long-term conditions, that kind of joint working with secondary care. There's pilots about consultants coming out at the moment. So kind of making sure that nursing kind of has its place in those sort of, in that MDT working as well, which builds on what you, as you say, builds on the bread and butter stuff that you do every day.
Yeah, definitely. Because if you think of a diabetic nurse specialist, you don't often think of them sitting within a GP practice, but we have many of them within GP practices. You normally associate them with secondary care. So it's about thinking about not only hospital nurses as being around the table, but primary care nurses being around the table as well, practice nurses with those skills.
So I'm happy for if people want to go away and reflect, and then if you wanted to, if there were any further ideas that you want to raise, you could send those to Catherine and myself. I'll put my email address in the chat. Also, if you felt that perhaps you were caught a bit cold today and that if you wanted a bit more time to reflect on this, happy to come back to a future meeting if genders allow. So just let me know if you would like me to do that. Thank you for your thoughts today. So I'll just summarise them and I'll just reflect them back to you. And then they'll go into part of the sort of, well, they'll go into the engagement feedback that we're getting. So we're talking to GPs, to other parts of the system, hospitals, community services about the ambitions for primary care. So all of the comments that we get will be sort of fed into the engagement process and then reflected back out into a new version of the ambitions. And it might be when we've done that reflection that I come back just so you can have another chance to look at them and see if kind of what you've said today has been reflected in the next version of the ambitions. As Catherine says in chat as well, the consultation's out for the 10-year plan. That closes on the 2nd of December. And I think it's open to organisations and individuals to feedback. So yeah, there's a further opportunity to build on the discussion that we've had in that consultation as well.
Okay, thanks everyone. Does anyone have any further thoughts or questions? Okay, I think Barbara will send around the evaluation form for the session. But yeah, that's it, I think. So have a nice day, everyone. Thanks very much.
Thanks,
Thank you.
Carol.